Okay, we're a few minutes past 1, so I think we should go ahead and get started here. So just a heads up for everybody that we are going to be recording this webinar. So we're going to hit record starting now, and I will kick us off. So welcome everybody to our webinar series, Vaccinating the Country Against the Novel Coronavirus. My name is Matt Wellington. I'm the Public Health Campaigns Director for US PIRG, and I'll be your moderator for today's discussion. And for our first panel here, we are going to dig into how to communicate effectively to the public about the COVID-19 vaccines and vaccination. Of course, there's a lot of issues that tie into that. So we're going to cover big picture messaging on the vaccines. We'll talk about transparency from policymakers and the importance of that, how to communicate in the media about these issues, and also, of course, healthcare providers communicating directly to patients about the vaccines. And I am going to introduce our stellar lineup of panelists in just a moment. First, just a quick thank you to our co-host, Doctors for America, for helping put this panel series together with US PIRG. And just another heads up is this Thursday is our second panel event of the series, which is going to specifically dig into how to reach marginalized communities with the vaccine. So I definitely encourage everybody who's joining us today to also join us on Thursday for that discussion. And so with that, I'm going to go ahead and introduce our panelists. So first off, we've got Dr. Rob Davidson, who is born and raised in Michigan. Dr. Davidson is a board certified emergency physician with nearly 20 years of experience in the emergency department in a rural West Michigan hospital. He's also the executive director of the Committee to Protect Medicare. Thank you for joining us, Dr. Davidson. We've got Dr. Christine Grady with us as well. Dr. Grady is a nurse bioethicist, senior investigator, and chief of the Department of Bioethics at the National Institutes of Health Clinical Center, Her research focuses on clinical research ethics, including informed consent, study design, recruitment, international research ethics, and on ethical issues faced by nurses and other healthcare providers. Thank you to Dr. Grady for jumping on with us. Helen Branswell is also with us today. Helen is a senior writer at STAT, an online news publication focused on health medicine and scientific discovery. She covers infectious diseases and global health. COVID-19 is the second pandemic that she's covered, and she very much hopes that it will be the last, and I hope that as well. And we have Dr. Saad Omer joining us as well. So Dr. Omer is the director of the Yale Institute for Global Health, a professor of medicine and epidemiology at Yale University, Schools of Medicine and Public Health. And he has conducted studies on respiratory viruses and vaccination programs all over the world. So thank you to all of our panelists for jumping on with us today. And just some quick idea for the audience here about how things are going to go. So each of our panelists is going to give some introductory remarks about the perspective that they bring to this issue. I've asked them just to keep it to a few minutes so that we have plenty of time for discussion. And then we will kick off the discussion, and we'll have audience questions through the Q&A. When the time comes, I'll let everybody know to start putting their questions in there. And I'm really looking forward to this discussion. So first, for his introductory remarks, we're going to pass it over to Dr. Davidson, who is going to talk about his experience as a healthcare provider in a rural, conservative-leaning community and how to reach those folks when we talk about the vaccine. So Dr. Davidson, take it away.
Hey, thanks, Matt. Glad to be here. As Matt said, I've been an emergency doctor in a small rural town here in West Michigan for almost 20 years now, and doing advocacy with the Committee to Protect Medicare. But, you know, my perspective on this is really shaped by 20 years of practice and by the last year in the pandemic here in a very, you'd say, conservative leaning. I mean, this, you know, I'm working in an area that's about 70-30 who supported President Donald Trump in both 2016 and 2020. And so, you know, we know from national polling that folks who support Republicans certainly have a bit more vaccine hesitancy than folks who identify as Democrats. And so that is a challenge in our community. I know for our hospital, we like to use local voices, primarily, you know, family practice physicians, emergency physicians who have been in the community as long as I have and others have, talking to people so they have a friendly face, someone in their community talking to them about the impact of COVID-19, how critically important it is. We're off of our peak right now. Our governor in Michigan has instituted measures since November that have thankfully brought the numbers down. But at our peak, we were routinely transferring people multiple days in a row, hour and a half away by ambulance, so their families couldn't be near where they were. So then when they're ready to be discharged, they had a difficult time getting home. Our hospital, always is challenging because it's a rural hospital, but during COVID-19, we had weeks and weeks on end. And even now we have days where if we get a few really sick COVID patients that go in our ICU, a couple really sick patients in a small rural ICU is almost capacity for the folks who take care of them. And so really to impress upon people what this does in our local community. And I think the idea of using anecdotes, using local stories, telling people about patients you took care of in their community who have been struggling with this disease sometimes goes a lot farther than statistics and numbers. And that's how we're trying to primarily communicate. And I think folks should be communicating in their communities.
Great. Thanks, Dr. Davidson. And I definitely want to dig more into how to get past the politicization of these issues, especially the vaccine. So we'll dig more into that in a second here. So now I'm going to pass it over to Dr. Grady, who's going to talk about background on the research behind the vaccines and how to instill public confidence in that process. So Dr. Grady, you can take it away.
Thank you for inviting me with this illustrious panel. I have been at the NIH for a long, long time. And so my focus is research, and I also do ethics. So I'm going to talk about both those things, but very quickly. I think despite the discouraging numbers actually of COVID cases and hospitalizations and deaths, vaccines are an example of a really great success. And they've built on decades of exquisite, really, scientific progress and research, but also on the coordinated efforts and contributions of many, many people. So the research, that's been going on for, again, decades, has led to opportunities to develop novel platforms for vaccine development, like the Messenger RNA vaccines that we currently have available to us under emergency use authorization. And in this past year, a rapid sequencing of the SARS-CoV-2 virus in January led to the design and development of these messenger RNA vaccines, which went into phase 1 clinical trials at a really unprecedented pace. And the research that ensued after that was a really coordinated effort between private industry, the US government, Operation Warp Speed, Active, a bunch of organizations, and the contributions of many, many people, researchers and research staff, research institutions, vaccine companies, the US government and other governments, and reviewers at multiple levels, including DSMBs, the FDA, and tens of thousands of clinical trial volunteers, so that we now have, as everybody knows, 2 vaccines being widely distributed through emergency use authorization, and others in the pipeline that are likely to come to the fore pretty soon. So the process was fast, but it was building on other important work that had gone before, and all of the critical steps were taken. The familiar phases of clinical trials occurred, the review was transparent, and the FDA issued the EUAs for these 2 vaccine candidates after concluding in a public meeting, actually, the advice of a public meeting, that the benefits of these 2 vaccines, very high efficacy rate with very low risk, were worth it. And so they issued the emergency use authorization in order to save lives during this really extensive emergency. So I just want to say a couple of things about ethics. So there are several reasons that everyone ought to get vaccinated. One is to protect themselves. The vaccines are effective and they're safe, and they're certainly much better than getting COVID. And people who get vaccine can reduce the amount of COVID, which will help ward off mutations of the virus, but also contribute eventually to herd immunity. So getting vaccinated is good. And some of what we see in the media is anger, frustration, confusion about how to get vaccine. There was a really great article in today's Washington Post that talked about the dominant feeling of some of the healthcare providers who have been vaccinated is profound and enduring relief, which is, I understand that. It's really like a light at the end of the tunnel. The last thing I want to mention is that because it was anticipated that there wouldn't be enough vaccine to vaccinate everybody who might want to be vaccinated once vaccines were available, there were a number of groups that convened and developed ethical frameworks to try to guide the prioritization of the doses of vaccines that we would have. And these various groups described multiple values and goals of allocation. The goals being reduce COVID by vaccinating those at highest risk, but also to preserve certain societal functions, helping to protect those of us who might be taking care of others, and reducing the burdens of disparate impact and inequities. And so the allocation priorities, as most people know, were healthcare workers, residents of long-term care facilities, followed by people who might be at high risk because of age and comorbidities or congregate living and things like that. But as vaccine distribution has rolled out, there's another really important value that I think, or goal, that people are now understanding and appreciating, and that is to try to get people vaccinated, as many people vaccinated as possible. And that requires being a little bit flexible about the priority schemes, but also putting mechanisms into place to make sure that we don't waste doses, that we get them to people as they're rolled out. And I think nonetheless, getting vaccinated is an individual choice and should be an individual choice.
Right. Thank you, Dr. Grady. And I certainly have some questions when we get started with the discussion about the emergency use authorization and how that differs from the regular process. But for now, we're going to jump to Helen Branswell, who's going to talk about this from a very different perspective than our first two panelists here. She's a journalist, and so she'll talk about the challenges of journalism covering COVID-19 and specifically the vaccines and some of her tips and best practices from the years doing this. So Helen, pass it over to you.
Thanks. And thanks for including me on this panel. It's a very interesting time to be a journalist, interesting in a good way, but also in not great ways. One of the big challenges with the pandemic is that, a lot of people who aren't used to issues like how vaccines are developed or ethical discussions about who should be prioritized for vaccine are covering these issues now. Reporters who were typically education reporters or entertainment reporters or sports reporters are all being drawn into the coverage of COVID. I would be surprised in a newsroom if everybody isn't working on COVID at some point in time or another. And that presents real large challenges because, some of us who've been working in this sphere for a while know things like, if you vaccinate a bunch of really elderly people, some of them are going to die within a few days of being vaccinated, but that doesn't mean the vaccine caused it. And other people won't necessarily know that and will jump on the story like we've seen out of Norway in the past few days, where there have been reports of, I think I saw 33 people who had died after getting vaccinated. Those will be investigated, but if you know about vaccines and you know about things like incidental events that can happen after vaccination, you know that you can't jump to conclusions, but not everybody will know that. That has been a big challenge and will continue to be a challenge as vaccines roll out. I've been puzzled by, let me start over. As Dr. Grady said, the development of the vaccines has been almost miraculous. I mean, to get to 2 vaccines in use in less than a year after the sequence of the virus was uploaded into international databases is extraordinary. People should be applauded for that, but I have been surprised by the lack of communications about things like, some things that happen after vaccination will be linked to the vaccine and some won't, and lots won't, and we'll investigate. And this is how it's done. I think that's been a failing. I know myself and others have written about this, but it shouldn't, I think, fall necessarily to the media to be, having to explain this to the public. I think, there should be some messaging about that. I think also messaging around the value of vaccination in general. That has been a piece of this that probably hasn't occurred to the degree that it ought to, probably because states are still waiting for federal funding and have been, terribly overburdened in the last year. But there's a lot on the communications side that hasn't yet happened and needs to happen quickly. I think I'll leave it at that.
Right. Thank you. And I love the story on the incidental illness. So thank you for writing that.
Thanks.
Yeah, super helpful. Okay, so we're going to pass it to our last panelist, Dr. Omer. And Dr. Omer was on our first panel a couple months ago about rolling out the vaccines before the vaccines were officially approved. And one thing he said during that discussion really stuck out to me, and that was that vaccine acceptance is a science, just like anything else having to do with COVID, and we should treat it as such. And so I asked him if he could talk about what does an evidence-based vaccine acceptance program actually look like, and what are the principles, what are some examples he can give? So I'll pass it over to him to close out our introductory remarks.
Yeah, so thanks for the introduction, et cetera, and the opportunity. And before I get into the specifics, I actually, well, not surprisingly agree with Helen. If I may call you by your first name, Helen, with your permission. But it's the same thing with science. There's a lot of scienciness going on in COVID-19 work. There were a lot of people, well-meaning folks, who do not quite understand the nuances of vaccine development, deployment, safety, etc., are engaged and are filling the communications vacuum with all the good intentions, but that's creating a lot of concern. And to, again, point to what Dr. Grady said a little bit earlier, the confusion about the process arose when a lot of people, as a knee-jerk, went after EUA as an example. EUA itself, how it's done is important, whether it's done with transparency, with independent advice, et cetera. But that blanket opposition in August, September to an EUA-based authorization, I think that's one of the reasons why a lot of people who only pay moderate attention to this kind of things are concerned about the process. That's not the whole story, that's not the whole reason. But I think we should be careful about how we talk about vaccines, and sometimes not sending a tweet is the best response, or not speaking up is the best response to an emerging story. So coming back to the evidence-based, and there are a few things, and I have the privilege of being part of the WHO Behavioral Insights Technical Advisory Group. It's a new entity that the director established. It's led by Cass Sunstein. I happen to be a member, and he and I and a couple of members spearheaded the development of this playbook, and I'm going to sort of and synthesize the evidence from a behavioral insights perspective. There are other tools, et cetera, that I'd be happy to refer you to, and that's one way of bringing it together. So there are three big buckets on which we should focus. The first thing is the quality of, an enabling environment to vaccination. So before you communicate, it's the overall, when you go to a vaccination place, are you treated with kindness, understanding, respect, ease? There are a lot of older people or people who are not used to interacting with the health system need to be vaccinated. The other thing is the information clear and accessible? So before we get to persuasion, just the basic information, and we are in an information deficit scenario, even with healthcare providers. The second bucket is social influences. We look at other people's behavior, and that influences our behavior. Ideally, you would highlight, if you were dealing with measles, one approach is to highlight the social norm. We don't have a social norm with COVID-19 vaccine because we haven't reached that level of coverage where we can say with a straight face that it's a social norm. All the cool kids have gotten it. Why aren't you getting it? But we can't do that. But there is another related phenomenon, which is highlighting new and emerging norm in favor of vaccination. So we can say that in terms of absolute numbers, millions of doses have now been given. And the fact that a lot of people who know best, like physicians, et cetera, like scientists, are getting vaccinated in droves and with eagerness. So highlighting that in our communications has some evidence behind it. The other thing is leveraging the role of healthcare professionals. And we had an insight that then was replicated, like we had an insight around childhood vaccine refusal a couple of decades ago, then has been replicated again and again and again, which says that even those who refuse vaccines, among other sources, trust their healthcare provider the most for vaccine information. Their overall trust in healthcare providers is lower than acceptors, but overall, compared to other sources like social media and other sources, it's the healthcare provider that remains a trustworthy source of information. So empowering healthcare workers, not just with information about vaccines, but approaches to communicate. So there's a whole body of literature now available in last 7 years that has been evaluated. It's not perfect evidence, like presumptive communications paired with motivational interviewing and different ways of approaching it in an interpersonal communication scenario that you can use as a sort of a training approach. Then once you have a social norm that is approaching, then you can amplify endorsements from key opinion leaders. But the next part of it is, beyond the social influences, is individual motivation. And that starts with trust, and that's been well recognized. And how you build trust, actually we did way back in August, September, we did these survey experiments, and we found that we gave people, randomized them into the timing of approval. And we found that an authorization of a vaccine a week before the election, and we actually anchored it a week before the election versus December. And that's when we thought that it will happen if everything goes through a normal process, meant that early approval would have resulted in substantively less confidence in this. So highlighting the process, that the process was followed. And that is good. We are paying, we will get dividends. So it's not going to take care of the whole problem. Then we identified, we randomized in the so-called elite endorsers. And a couple of people may be familiar to some of my fellow panelists, including Dr. Fauci, who we randomized people saying that different backgrounds of people, his endorsement, negative, if he had negatively endorsed a vaccine, then we would have forgotten about this vaccination program. If he positively endorsed, meant that Democrats moved more, but Republicans and independents also moved in terms of their trust and intention to get vaccination. So leveraging the right kind of elite endorsement, and then bipartisan endorsement was important. One party endorsing sort of prominent figures, the president versus the speaker, had limited effect and only in subgroups, but both of them endorsing did move people. So highlighting these kinds of right kind of endorsements and so increasing the salience of that would be helpful.
And then, Dr. Omer, I just want to jump in and ask for just one last thought.
Mm-hmm. Yeah, and the last thought is that there are a few novel things that we can try out, and I'll pause here. Essentially, there are a few early insights that can be applied, and I can discuss that in subsequent discussion.
Okay, that's great. So thank you to all of you for those introductory remarks. I think I've definitely got a few questions from those. I want to start with one question that came up in the last couple of days more and more, and that's the big picture messaging behind the vaccines. And there was this column in the New York Times, I think yesterday, about, claiming that we've been underselling the vaccines. And I think I wanted to open it up to this group to talk about, first off, what do you think? Has there been an underrepresentation of the opportunities behind the vaccines and what they represent, and what life will be like after the vaccines? And second, follow-up question is, how do we walk the line as health professionals, or how do you walk the line as health professionals and communicators of giving people hope because the vaccines will help us get back to normal, right? Versus making sure they're properly educated about the limitations and the expectations of what life will be like after they get the vaccine. So, what are the side effects going to be? Will you be able to go out and see your friends and hug your grandparents after you're vaccinated? How do you walk that line? So I'm curious, I'll open it up to all of you, whoever wants to start first there.
I'll start.
Yeah, go ahead.
I think it gets back to a little bit what Helen was saying earlier, that, you know, messaging is critical, and messaging is both, is caught, I think, a little bit between too much information or different takes on information and simple messaging. You know, it's hard to do all of that at the same time. There's a ton of information about the vaccines available, maybe too much in some respects, but I think the amount of information sometimes actually does create an inaccurate picture, you know, because people don't have time to go through it, and they don't have, as Helen said before, necessarily the background to understand all the details. And so then the simple messages take the fore, and some of them are misleading, and some of them are confusing, and some of them are negative. And so messaging is really critical and hard.
Right.
I would jump in if you don't mind.
Sure.
I mean, you know, one of the funny things about this is that in the lead up to the release of the data for the first couple of vaccines, everybody was worried that we wouldn't have highly effective vaccines. That, you know, they might come in sort of at the 50-60% efficacy. And then 95 came out, and it was, I can tell you, none of the scientists I spoke to were expecting 95. They still sort of start chuckling with glee when that number comes up. You know, it's extraordinary. But you can understand why people were trying not to oversell the vaccines in the lead up to the first data releases. And we don't know that the other ones that are coming down the pike will be as effective as those. So you have to be careful about what you say to people. The other thing is, I'm not the right person to ask about, you know, well, we need to continue to take precautions. I have some, I know what I've heard, but I'll let the doctors answer that. But I do think there are some really important unanswered questions about these vaccines, and these questions will take time to answer. And so it's hard to jump to conclusions. It's not known if people who get these vaccines can be infected and can transmit. We still don't know about transmission. So that's an important question. Hopefully they reduce transmission, which will reduce the burden of you know, the virus in the community. We don't know anything about the duration of the protection, and that's going to be really important. There are all these new variants coming up these days, and studies are, you know, frantically underway to try to determine what the impact of the variants will be on the quality of the protection the vaccines generate. But so there are a lot of unanswered questions, and it's sort of the nature of scientists not to try to oversell things, I think, in the main. So I'm not surprised if people are sort of not trying to be too rah-rah.
Yeah. And before we keep going here, I'll just say to the audience, if you have questions, please start to put them in the Q&A function, and we'll start to work those into our discussion here. If you're putting a question in, just please include your full name. If you're a member of the media, also include which outlet you're representing, and we will do our best to work those into the discussion here. So, you know, I think, Helen, your point rings true. In our first panel back in November, I think mostly our panelists were pretty measured about how to represent the vaccines and what people should expect afterwards. So things like, you know, don't think of it as you're going to get your vaccine and then the whole thing's going to go back to normal. You know, we're going to be going back to parties. So that was helpful context. So I'll leave it to Dr. Davidson or Dr. Omer if you want to also weigh in on this question.
Yeah, I think I agree with what everyone's saying. And I think, though, that those of us in the clinical world who are directly communicating with patients, either through, you know, larger media platforms or just one-on-one. My wife's a family doctor, and she gets at least a dozen messages a day in her inbox, people asking her, what do you think about the vaccine? And this is happening, I'm sure, I know, to primary care doctors all over the country every single day. And I think we have to first decide, do we accept the science? Do we accept the efficacy numbers? Do we accept the panel's recommendations? I do. I think we should. I think we should communicate with one another that that is true. And then I think we just sort of leave the nuance for the scientists to communicate to us as time goes by. The reality is, without vaccines, at 94%, at 70%, at whatever percent efficacy, we are stuck telling people to wear masks and stay away from each other till it burns through and we get that dreaded herd immunity and 1 million and some odd people having died from it. So without a vaccine, that's what happens. With a vaccine, well, we will get back to normal, right? We don't know exactly when. We know that I know that if I'm vaccinated and my elderly parents and in-laws are vaccinated and all my kids are vaccinated, we can get together in a safer way wearing masks for slightly longer periods of time, and we can tell people this. I think that is true. There haven't been vaccines that have decreased serious illness, but haven't decreased the likelihood to actually contract less serious illness or then transmit it. I mean, I think the idea that this would be a vaccine that would keep people from getting really sick, which is what the study showed, but somehow not keep people from getting asymptomatic infection that could then transmit it, that's strange. That would be very strange if that was true. So I think it's extremely likely that these vaccines will decrease the likelihood of transmitting once all that data comes in. And as far as duration, you know, the people from those original studies, they're about 3 months ahead of all of us, and they're monitoring these folks. And so we're getting that information in real time. Those of us who got vaccinated very early are always going to be about 2 to 3 months behind those folks in the studies. And so as the data comes out, the recommendations will come out. But for right now, it's like, we got to be gung-ho and really selling this as the only answer, even if we all know somewhere in the backs of our minds, it may not be the perfect answer for all folks.
Right. And that's really interesting because that's how my family members are thinking about the vaccines when they call me asking about them. You know, my mom calls me and says, I can't wait to get my vaccine so I can come up and visit you. So, the more that I think we can couch it in those kinds of, here's what, you'll be able to get back if you're vaccinated. But I also just think it's probably part of the big equation on the messaging is being super clear and simple, as Dr. Grady said, but clear and simple with what we know, but also what we don't know, right? So it sounds like you're thinking, it would be pretty unlikely if this didn't reduce transmission, but we also just don't know that for sure right now, and we should be clear with that.
Yeah, and I think the other reality is, this is not a criticism of Americans or humans in general, but humans in general are fairly selfish, species. We are thinking of ourselves and our families and maybe our communities or our church, the people that directly are around us. A lot of people care a lot about people outside of themselves, but brass tacks, that's the way I think we get, particularly folks who are skeptics, folks who are a little bit leery, who are sending you messages saying, I don't know, I'm a little bit worried about this, that, or the other. I think we have to convince them what it's going to do for them, what it's going to do for their families and their communities.
Right. So Dr. Omer, do you have any thoughts on this question before we move on here?
Yeah, but briefly, I count myself in the more optimist camp, but cautiously optimistic. And here's the reason why. Wearing my sort of vaccinologist hat, here's what we know about this vaccine. We know that it is, the vaccines that are authorized are highly efficacious. We know that this is not the first, we're not inventing new biology. These are new vaccines. The biology is the same. And so based on our priors of how vaccines work, at the end of the day, at the terminal level, how the immunity is induced it's a protein subunit vaccine, mRNA vaccines. At the end of the day, we are delivering a vaccine to the immune system, an antigen, a protein antigen to the immune system. And we think with this level of efficacy, the immunity is unlikely to wane within 6-7 months. It's not going to be a month kind of a calendar. And so if you go beyond a horizon, a reasonable level of confidence based on your priors, in terms of beyond a year, then we are in flu vaccine territory, and getting vaccinated every year is not the end of the world. And so that's, thinking through that. The big threat is these variants that are evolving. Not every variant has the same level of evidence of these vaccines working. So there are a few concerning signs. So that adds to uncertainty. In terms of the reduction in transmission, it is unlikely, based on animal data, based on our understanding of coronavirus biology and other respiratory viruses and how vaccines work, it is unlikely that we are going to have the same level of protection against transmission. And it is highly unlikely that we will have zero transmission protection. So we are looking at imperfect transmission scenarios. So these are our priors. And building, how do we build on that science and be honest with the public while making sure there are enough incentives for people to get vaccinated? And here's how you do it. Building upon, I'm not saying something new that's been said in this panel as well. So you decrease the confusion by communicating a certain uncertainty, but having message discipline from the public health. So if everyone is saying the same thing, at least at the public health authorities level, you understand that this is an issue of uncertainty, not necessarily a cause for confusion. And so that's a subtle difference. So having message discipline that communicates that. The other thing is, I think the science supports a message of cautious optimism that says that things will not go back to the old normal, but things will be much better than they are if enough number of people get vaccinated. And so there's a nuance to that message. And so therefore, by the way, I don't buy that sort of that op-ed kind of a thing where I think it's right now, it's a four blind men and an elephant. Everyone is saying that different people are saying that it will go back to normal. People are saying it won't go back to normal. So people are overselling and underselling and right selling the vaccine. That's the current scenario. But I think the evidence supports a message of cautious optimism that doesn't oversell it, but provides incentives for people to get vaccinated.
Right. So I've got a number of audience questions here. So I want to transition to one of those. And this is from Elsa. And she's asking, how do we encourage healthcare workers in conservative areas, particularly those who might be seeing conspiracy theory related news or misinformation to get the vaccine? And this is, I think, part of a larger question that I have. So Dr. Davidson, you mentioned earlier, Republicans typically have more vaccine hesitancy. I looked at a recent poll from Gallup, and it showed that overall 65% of Americans polled said that they would be willing to get the vaccine. 85% of Democrats, 45% of Republicans, and the Republican number had dipped recently. So this gets into that larger question as well. So I think we'll start with you, Dr. Davidson, and then we'll open it up to the rest of the panelists to answer that one.
Yeah, for other healthcare providers, and I've had a number of nurses, nurse assistants, techs in the emergency department, in the hospital in general, paramedics, come in and ask me, so what do you think? I'm not sure. I've heard this, I've heard that. I think we lean on the trust that these folks have in us in general, because particularly if we've been working in the community for a fair amount of time, I think we get others of our colleagues who also are accepting of and excited about the vaccine and getting people vaccinated to do the same. There's a linguist, I hate to bring this in, but linguist named George Lakoff out of Berkeley, who might be retired now, who talks about framing. And I don't think we try to negate the frame of what they've been hearing. I don't think we attack the conspiracies. We don't attack those negative messages. We just have to profoundly overwhelm the senses with the positive messages, and in addition to, showing them your arm where you got the shot. I got the shot, the first of the Moderna, about 3 weeks ago. I'm getting the second one coming up next Sunday. I think that proof also, they trust you, you got the shot, other colleagues got the shot. I think that's all we can do, really. You can certainly direct them to references, direct them to sites that can tell them more. But my guess is they know how to find that. They know how to, find both sides of this discussion, and they have ample opportunity to find it. But you, as the trusted voice, I think you just have to really lean on that.
Right. Other thoughts from panelists on this question?
So, a couple of things to build on this. So these are we can learn from how we communicate to quote unquote expert audiences. And so the lessons from there is, number one, trust in process, in the process. The process has been transparent, but it hasn't been communicated as vociferously, as effectively to these kinds of providers who are not paying attention to the process itself. So that it's not that this is what happened, but contextualize it. This is the mainstream process that has happened. Yes, there are differences between what you would do in a 5-year development plan and 1 year, and these were the reasons, etc. So that's number thing. number one. The second thing is there a lot of concern comes from so-called information deficit. So a family practitioner in Ohio doesn't necessarily know how an mRNA vaccine works, but they can be taught that fairly easily. Having done that in the context of other vaccines with new recommenders of vaccines, we have experience doing that. So number two, bridge the information deficit with easy to digest, CME type information. So that's number two. Number three is an interesting concept of anticipated regrets. And so people don't realize that a lot of times if they have given up their turn, they may be in a much bigger group to get their vaccine. So it's not a matter of postponing it by a couple of weeks. If you give up your turn, it may be that it comes a lot later. So that's a subtle concept without being too draconian about it, communicating that it's not now or never, but it may, and if you're an ICU doctor and if you're refusing right now, I think every institution will make an exception and come back and vaccinate you, even if you change your mind, after a few weeks. But if you are not directly engaged with patients, et cetera, and you decline that, I think it's reasonable to communicate that your turn may not come until April or May. Then you should get in line with everyone else, and so on and so forth. So anticipated regret is a behavioral concept that, again, we can employ to these specific targeted audiences. So these three things for healthcare providers.
I'd love to contribute a comment about nurses, because I think nurses are a very large part of our healthcare workforce, and they are very trusted by the American public. And yet there was I think disappointing or concerning survey that the American Nurses Association did in October, where they surveyed 13,000 nurses in the United States, and the willingness to take a vaccine was very low, actually, among those 13,000. And the reason that most of those nurses gave, the most common reason, was concern about the speed of the process. And so just what Dr. Omer just said, in order for the healthcare professionals themselves to trust the process, they have to understand the process. They have to understand why it went fast, how it went, and what was the sort of outcome of all of that. And I think they can learn that, and they can understand that. I would be really interested, although I am not going to do this, and I don't know that ANA is either, but I would be really interested to see how those numbers have changed since October, because we've had political changes, we've had 2 now available vaccines, and I would really love to see the kind of acceptance among nurses as an example. But I think nurses have a huge role here, and they have the responsibility to be as informed as they can and to represent the information as well as they can.
Right. So there are a lot of healthcare providers on this call right now. So I think this has been echoed a couple times, healthcare providers, they might not be paying attention to this process because they have other things going on in their own settings, but they can learn it. And so are there materials out there that folks can refer to that we could even potentially send after this panel discussion to the attendees? Do those, exist right now? What are they? And I'm just curious, because then we'll also send them out after this panel.
So there are just a couple of resources that I would recommend. There is a page on the American Nurses Association website with resources, and they have a specific page for vaccines with lots of details about vaccines. I think that's very helpful. I think the CDC website actually has a lot of good information about vaccines. And then for people who want very specific information about the 2 vaccines that have been authorized under the EUA, if you go to the FDA website, there's a page you can read it for providers and also for patients. And those are really pretty succinct summaries of the information about those 2 vaccines.
Yeah, and I should plug this as well, that our co-host Doctors for America has a great FAQ about vaccines that we're also going to send out after this panel to everybody who's attending. And that goes through some of these common questions and answers, and I think they're going to update it regularly. So this information's out there. So I think before I jump in with another audience question, I do have a question for Helen specifically about what it means to be a good source for media when healthcare professionals are talking about the vaccines, because as Dr. Omer mentioned before, everybody is all over the place, right? There's all kinds of messages out there. There's over optimism, there's under optimism. So, and of course, like how do we actually get the facts? So based on your experience, what makes a good source, especially when you're covering vaccines? What do you look for? What questions do you like to ask?
I'm really careful about talking to people about issues that are in their sphere of knowledge. What happens too often, I think in part it's because of television. People become known as somebody who can speak, who are willing to be interviewed, who can speak clearly, who seem to know what they're talking about. And sometimes reporters go to them for everything. And I just think that's a really bad approach. Nobody knows everything. And I've always found that somebody who says to me, that's outside of my sphere, I shouldn't be the person you talk to about that. They go up in my esteem. I trust them more in the future. If I want to talk about vaccine, I go to people who know about immunology. I go to people who are vaccinologists. I go to people who've conducted clinical trials of vaccines. Those are the people I want to talk to. I mean, if I want to talk to somebody about how to message about vaccines, I will go to people who work in the field of vaccine hesitancy. But you cannot assume that just because somebody is eloquent about one part of the COVID story, that they know all parts of the COVID story. Nobody can, and it's not a good idea to use sources in that way.
Right. And then I think probably some of our panelists here have been sources for the media on COVID, and I'm sure Dr. Omer on the vaccine. So do you all have any thoughts about healthcare professionals speaking to the media, and any thoughts you'd want to give?
I just echo what Helen said. I've declined, interviews with folks who you get to know, who get to know you, who trust you, and then want you to speak to some specific aspect of this. I'm happy to talk about, sort of how it works where I am, and then what organization is doing about this. But, it's almost that idea, stay in your lane. I mean, I think, we all, as healthcare providers, we have a breadth of knowledge, but if people want to drill into a depth of knowledge that really isn't in our wheelhouse, we just need to be straight with them, and don't misrepresent, our expertise.
Right. Okay, so I've got another audience question here, and switching gears a little bit back to clinical trials and the vaccines and safety. So this is from Terry, who's a nurse educator in Oregon. So she wants to know, kids who are 12 to 18 now being included in a clinical trial to get children vaccinated, how will babies to 12-year-olds, so younger children, be included in trials in the future? And what are some of the surrounding ethics of children in these trials? And I actually want to add something else onto this too. So Dr. Omer, in the last panel discussion, you expressed the need for more data on pregnant women, I think, and how that was not, we didn't have that at the time of our previous panel. So I'd like to add that also into this question. So I think we can start with Dr. Grady, if you'd like to begin, and we can open it up to the rest of the panelists.
So just thinking about the way we ethically do clinical trials, if this is a disease that affects adults as well as children, it makes sense to start testing things in adults first. And that's what did happen. The companies that have vaccines under EUAs are beginning to test them in children. And they're doing it, as I understand it, in a age de-escalation way. So they're starting with people who are close to age 18 and working their way down in the scale. So I'm assuming eventually they will get to infants, but I don't know how long that will take. Similarly, there have not been studies with pregnant women, and for some of the same reasons, that it's not the place where you start when you're doing a clinical trial. There's been some data from the clinical trials that have been done, that there were some women in those trials who became pregnant during the course of the trial. And, that what this suggests is that none of those women had any problems with the vaccine, let's put it that way. And so the recommendation from the CDC is that women who are pregnant or breastfeeding should work with their physician to decide whether or not to take the vaccine. And I think it probably depends on their own health status and their own exposure to risk. Eventually, there will be bridging studies, hopefully, to try to understand how safety and efficacy is seen in pregnant women and in children of all ages. That's my understanding.
Thank you. And Dr. Omer, are you going to chime in? It looks like you're about to speak.
Yeah. By the way, feel free to call me Saad.
Saad, okay.
One of the things, I agree that this is how things will proceed, but I think stepping back, I think we could have done things a little bit better as a field. Having done trials in multiple countries with pregnant women, I can tell you that it's not, all of us think a lot about the risk and stages of pregnancy, safety, ethics, all of those things, and we take this very carefully. For example, it was absolutely reasonable not to include pregnant women in the initial trials. Having said that, why didn't we have a pregnant women trial lined up irrespective of the vaccine? Why did we not have pre-consented pregnant women where you explain the process, enroll them, and do a second consent when the vaccine characteristics become available so that you're ready to go? So because we need sort of innovation in trial design, et cetera. Why is that DART study, developmental and reproductive toxicity studies, are only now becoming available? Pregnant women should not be an afterthought. So that's another thing. The third thing is, and you will see me, and Ms. Branswell will know that when I have to push a point, I jump up and down a few times in the media, on social media, etc. And this is one thing I'll be jumping up and down about before the next pandemic, which is that we need better animal models for pregnancy, so that we can there will never be a substitute to human trials, but a better animal models in pregnancy, that's the science that we need to invest in. Right now, I feel based on the phase 3 data and the DART data, I feel very confident going into trials of maternal vaccination. So just to know that, but that process could have been sped up if we had sort of better models earlier on. And the last thing is, one thing, look, Operation Warp Speed did a lot of good things in terms of developing individual vaccines, but a vaccine development plan is more than getting to licensure and authorization. And I'm not just talking about deployment, but a strategic level thinking that that if your vaccine is highly efficacious. So some of these secondary studies are bridging studies that Dr. Grady alluded to. And these studies do not require, and it's not feasible for every research question to have 30,000, 40,000 people enrolled. And the way you do these bridging studies is that you do a large study or two, and then within that you identify a correlate of protection, an immune correlate of protection, a biomarker or an antibody level, or a sort of a kind of cell-based, cell-mediated immunity response that tells you that this person will be individually protected. And then you do smaller studies and see that these few hundred people, whether they reach that benchmark or not. Right now, this should have been a super high priority to get a correlate of protection. And one of the reasons we don't have a correlate of protection is that part of that analysis is these breakthrough cases, meaning those who are in the vaccinated arm who get that disease is part of the computation. But the problem with that is, that's a good problem to have, is because the vaccines are so good that we have very few such cases. How do you bridge that problem? So you bridge it by stepping back and looking at the whole program and pooling data from 2-3 trials. We have had the immune response that is protective is unlikely to differ, and that actually defeats the purpose by the vaccine product in terms of protected, non-protected. Why are we not pooling the data?
Dr. Omer, I just realized we've only got a couple minutes left. So I want to...
So the bottom line is, if we had that, we would be doing, I would be doing pregnancy trials right now.
Right. Thank you. So since we only have a couple minutes left, I want to ask one question for all of the panelists to go through and give their thoughts on. Obviously, we are not where we hoped we would be with the vaccine distribution. And I know the latest numbers I saw, we've administered 14 million shots in about the last month. That's about 44% of the vaccine doses that have been distributed have actually been administered. So I would love to hear from the panelists what are the top line things you would want to change right now? And of course, President-elect Biden has a plan that came out to change some of these things. But what are the top line things that you would want to change now, both in terms of communication and transparency from policymakers as they're trying to build out this massive vaccination program, and also things that you think should streamline the distribution, whether that's placing less emphasis potentially on the prioritization or whatever it might be. So let me pass it to the panelists for final thoughts on that, and I think we'll have to wrap up after that. And just quick thoughts if you can, because we've only got a minute or so left.
I'll start if you don't mind.
Yeah.
I'd love some transparency on how much vaccine is being made, at what kind of a pace it's being made. There isn't very much information about that. I think, it's a great idea to try to vaccinate 100 million people in 100 days. I'm not sure how much vaccine there is going to be in the next 100 days. And I'd really like to have a better idea. It's one thing to tell people, don't get so caught up in the staging, call more people forward. Like Alex Azar did last week. He called forward 100 million people and said, you should be able to get vaccinated now. There isn't enough vaccine for that many people. We need to be realistic, and we need to be, the government needs to be realistic, and the government needs to give people a more fact-based idea of how soon they can be vaccinated.
Thank you.
Yeah, I think building on that, once we have enough vaccine or more vaccine, I think it's getting funding necessary for local health departments. We have a health department. I know the numbers for the county adjacent to us. For a county of about 150,000 people, they have 8 permanent employees of their health department. So trying to do testing and tracing, trying to do all the other work of health departments that aren't related to this, and then trying to be part of rolling out vaccines. They missed a deadline to get a certain number of vaccines, and now they've been kind of pushed back a month. And so, yeah, that I think is critical once we know where the vaccines are and how many we have, to have the funding for the people to give them.
Right. Dr. Grady?
I agree with both of those things. We need to know about vaccines, and we need to have resources at the local level to be able to distribute them. And, the people who are distributing them are doing the best they can. But it is very hard with the amount of people they have, the amount of space they have, getting logistics into place. I mean, it just, got to give them a little bit of slack. They're doing a great job.
Right. And then Dr. Omer to close us out.
Yeah, so immunization programs sink and swim based on local micro-planning, not just overall strategy. We should have resources to support local micro-planning, local troubleshooting, et cetera. And that's what we absolutely need to do. We needed to do that yesterday, but tomorrow will suffice.
Tomorrow will suffice. We'll end it there. So thank you so much to our panelists for joining us on this panel discussion. This has been super helpful for me, and I'm sure for all of the attendees as well. Just a reminder to everybody that the second panel in our series is this Thursday, specifically about how do you reach marginalized communities who historically have had difficulty with vaccination. So please join us for that on Thursday. But again, thank you to our panelists, and thank you to our co-host, Doctors for America. Have a good rest of the day, everybody.
Thank you. Thank you
Thanks.
very much.
Bye, everyone.
Bye.
Thank you.